this time I will show you my result in the intraoperative mapping of pachymetry during the procedure. Briefly, the cross-linking, as I mentioned yesterday, is a photochemical reaction in which you put a riboflavin into the cornea, you soak the cornea with the riboflavin, then you irradiate with a UV, and the combination of this produces oxygen radical that make the cross-linking reaction that stiff the cornea. Actually, this is the effect, the compactation of the anterior lamella and the flattening effects that is useful for keratoconus or ectasic diseases. And sometimes we have also a very beautiful result, as you can see here, with a flattening of more than 5 diopters in the central zone, and in this case also a real improvement in visual acuity. But why intraoperative pachymetry must be part of our conventional procedure? This is a study from Kimionis in which he showed how during a corneal collagen cross-linking, the cornea shrink for more than 25% during the procedure. So you start with a cornea of 500 micron, but before you irradiate, you have a cornea sometimes of less than 300 micron. So we're a physician, and so we have to follow the Hippocratic oath, and the first rule is first do not harm. So before performing any surgery, you have always to keep this in mind. And cross-link is not a so safe procedure, especially the traditional cross-linking. We sometimes also experience some real complications like lamellar keratitis, the stromal scar, and corneal edema. This is a typical finding after a normal cross-linking. We can also have an early onset AIDS after cross-linking, but this is not a complication. This usually vanishes with the steroid treatment after 1-2 months. And sometimes we have also a late onset AIDS after cross-linkings. This is not a real complication because also in this case with the steroid treatment the things goes well. But I want to show you my skeleton in the cupboard, and this is a tale of conventional epi-off cross-linking. This was my patient in which I performed an eventful procedure in the other eye, and because of there was a keratoconus in progression, I decided to perform a conventional cross-linking. As you can see, the cornea is really good. We have more than 500 micron of thickness, so this is the ideal procedure for a normal epi-off. But look at the day post-op. Have a diffuse lamellar keratitis, as you can see in the OCT and a slit lamp, and I immediately start to give steroids at a high dose, 5 times per day. And this is the situation after 20 days. And I start to taper the steroid, and finally, after 8 months post-op, I have a paracentral scarring, as you can see. And if you look this from a refractive point of view, I have a corneal flattening, but this is a good effect. But in reality, this was a complication. I was lucky. I was lucky because the scarring was paracentral, and the patient had a hyperopic shift, and he recovered his pre-op visual acuity. So in this case, I was lucky, but I started to ask a lot of questions. It could be an avoidable complication. Look at the intraoperative OCT. This is the cornea before the treatment. This is the cornea just after the soaking, after 30 minutes of soaking. It's a completely different eye. We have a shrinking of more than 250 micron. And in reality, the surgery was not so good because the patient was noncomparative. I did a frequent recentering, and the procedure took more than 60 minutes. And the complication probably it will be avoidable if I change the protocol looking at the intraoperative mapping. And but was too late. But I remembered what my Italian colleague said, that in cross-linking, the thickest cornea thin at a higher rate than the thinness. That's probably because we have more interlamellar interfibrillar space, so more water and more possibility to shrink. So the take-home message from Ellen Albert was that CCT reduction during the second phase is a predictive factor for the development of a stromal opacity after the procedure. So finally, the intraoperative pachymetry must be part of our conventional procedure because of consistent and unpredictable corneal shrinking. So I start to go over why the pachymetric mapping should be part of this procedure. If you perform an ultrasound pachymetry, you just measure one point of the cornea, and it lacks of intraoperative repeatability. I challenge you to find always the same point when you do with the ultrasound. And also in keratoconus, the thinnest point is eccentric and variable. When you perform a map with the OCT, we have no contact mapping of the whole cornea. It is for sure repeatable. You have a precise definition of the thinnest points, and you also have an in-vivo imaging of the cross-linking process. The other question to answer was why the cornea shrink. We have to look at the excipients. In the original formulation, the riboflavin was combined with a dextran 20% solution, and the dextran is hyperosmolar, so it pumps out the water from the cornea, and it substantially shrink. But if you use an isosmolar solution like HPMC, the cornea, for chemical reason, remained just stable. And we have some suggestion from the lab. As you can see, if you look at the dextran solution, we have a substantial shrinking of the cornea compared to the simple water. And if you look at the dextran-free solution, the cornea substantially is the same, it does not shrink. So we start to study this solution that we call it VIBEX6, that is a solution of riboflavin without dextran, but with methylcellulose. And as you can see, also the spread of the riboflavin through the cornea is more rapid respect to the dextran. So the cornea does not shrink, and you reduce the soaking time. That's the reason why the original formula with the dextran was eliminated, and actually we just in the market there is just the dextran-free solution. So this is the study, 25 eyes of 25 patients. I measured with the OCT the map before, pre-op, after epithelium removal, after soaking with the riboflavin, and after irradiation. I also measured not only the central corneal thickness, but the inferior paracentral corneal thickness. This is the average of the three inferior paracentral octants. This is the accelerated protocol. We have a 30 milliwatt energy, 7.2 joule of energy delivered, and the soaking time is 10 minutes. And if you perform a 30 milliwatt, you have 8 minutes of irradiation. 4 minutes on, 4 minutes off. And look at the cornea, before and after. It's quite the same. If you look also at the pachymetry assessment, the minimal corneal thickness is 392, and after it is more, it's 398. But substantially, the cornea, as you can see in the slit, is quite the same. This is another example. The cornea remained quite stable during the whole procedure. This is the result plotted about the central corneal thickness. As you can see, after the 50 micron of epithelial removal, the corneal shrink, but of about 10 micron, not more than this. And also looking at the other parameters like the difference between the superior and inferior occlutants, the minimum thickness, and the difference within the minimum and the maximum thickness of the cornea, all the values are very, very flat. So this is a proof of the stabilization during the surgery. And if I ideally plot this procedure with an old procedure, you can see how you save a lot of time, and also your cornea is very better because it's not exposed for 30 minutes to the air. So also we reduce the possibility of infection. But if we use the newer cross-linking machine, we are more safe. More safe, why? More safe because we can customize the power. We can customize also the energy delivered to the cornea. We actually shifted to 7.2 joule without any problem. We have a superior beam profile, and we are also a more precise focusing of the spot. What I mean when I speak about the beam profile, if you look at the older machine, they always have a hot spot. That's just because the flat beam allows the cornea to absorb more than 9 joule in the center and less than 3 joule in the periphery. So you have a very uneven cross-linking effect, and more cross-linking in the center respect to the periphery. And if you look at the new machine, they have a flat beam that covers the cornea easily from the center to the periphery. So you have more volume of cross-linking in the periphery. And you remember that keratoconus is substantially an ectatic disease of the peripheral cornea. And this is true because if you look at this study, you can see how with the old machine, the keratoconus that went very well for about refractive result was the cone located in the center, not in the periphery. This is the result of the flat beam that is more active in the center respect to the periphery. What about the focus? The focus is very important during the procedures because this is the energy if you work, if you had an excessive working distance. This is essentially an ineffective treatment. This is the spot where when you are too close and you have the risk of a hot spot of a central burning. This is the spot, the even spot when you work at the correct distance. But look at the defocus. If your defocus is about 1 millimeter, you have a 10% reduction in the energy. If you decenter for 0.2 millimeter, you have in the same way a 10% of reduction of the delivery. But if you decenter for more than 0.5 millimeter, you have a 20% reduction. And with the new machine, you have a pointer like in the refractive laser that is very, very precise. What about the safety? This is a study in which we also compared the UVA absorbed by the cornea. If we start from the anterior cornea, you can see how with this method, when you reach the deepest cornea, you have no energy that could damage the endothelium. So this is a very safe technology. And if you compare it to the standard dressing protocol, in the deeper cornea, it's quite the same. And how we can translate in the clinic? I performed also OCT just after the procedure, and as you can see, you can appreciate hyperreflective band that is very even from center to the periphery. And after 7 days, you can see the demarcation line that is very evident after 30 days. And as you can see, the depth is the same from the center to the periphery. And this is the eye 3 days after removing a contact lens, and is really a quite good eye. So, ideally, what about safety? we want to cross-link the anterior third of the cornea. We don't want to go more because we can go very near to the endothelium and we have the risk to damage. And ideally with this technique we are here. So, in conclusion, the Epi-off accelerated pulsed cross-linking with the use of dextran-free limited the central and paracentral corneal thinking during the whole procedure. After the epithelium removal, we observed just a statistically significant decrease, but was very mild, just after the irradiation phase. And wide-angle pachymetric mapping showed a smooth thickness variation during the procedure, and the safety of this procedure is supported by this objective finding. And thank you for your attention.
Thank you very much. Beautiful presentation and right on time. Any questions? Okay, I guess that's a good sign.